The first thing I want to go over is just to give you an idea of how pain after surgery has traditionally been done, and then give you some ideas of how, with the improvements in research and technologies and techniques in anesthesia, we are able to now get patients better, getting back to normal faster. And then finally share some data with you, which will demonstrate how if we change the way we do things, we could profoundly affect care. Traditionally, I would argue that pain after surgery has been very reactive in nature. If a patient complains about pain, they get a pain medicine, often an opioid pain medicine. If they got a spinal anesthetic, we could give them intrathecal morphine or Duromorph. If it's a, quote, big surgery, a painful surgery, we'll often ask to give them, the patients a PCA with morphine or Dilaudid. You go back a day or two later, and they're in IV medications being transitioned to PO, and when they're tolerating PO medications, they get to go home. And don't get me wrong, I have nothing against opioids. They're effective, we need them, and they're very good at what they do. It's just that they have a lot of side effects. Things like nausea, vomiting, constipation, sedation. And the picture at the bottom there, probably one of the worst ones, is if you have to use the Foley, urinary retention. So with the technologies and techniques in anesthesia, I hope to show you that we're trying to do a more patient-centered approach, more than just giving an opioid whenever a patient has pain. I'll talk to you about ultrasound-guided regional anesthesia. I'll talk to you about catheter-based perineural anesthesia, and tie those into a whole multimodal approach, where even simple things like acetaminophen, Tylenol, NSAIDs, COX-2 inhibitors, and neuropathic medications like pregabalin and Neurontin. So hopefully by the end of the talk, you'll see how we are getting patients back to normal faster. Patients are more comfortable. They are taking less pain medicines, less side effects to pain medicines. I'll share with you some data which we've shown that patients are now safer with these types of regimens. Their rehab is easier. Their patient satisfaction has gone through the roof. You put all these things together, they have better outcomes. And then with better outcomes, you could even do all this with decreased cost. So what is multimodal analgesia? This is a cartoon of how a painful surgical stimulus could get transmitted up to the pain. It's how the signals that allow us to perceive pain. The surgical stimulus will start in the skin, travel through the tissue along nerves, up the spinal cord, up the central nervous system to the brain. And just as important as this pathway are also the mediators that are along this pathway. A lot of them are endogenous, things that are always there, and some of them are exogenous, some of the medications we give. I'm going to spend initially some time talking about local anesthetics and some of the nerve blocks we do. A lot of people in this room are very familiar with peripheral nerve blocks and regional anesthetics. These are two diagrams of some areas where we can deposit local anesthetic to make patients more comfortable. The diagram on the left is a picture of the brachial plexus from the neck as it goes down towards the shoulder and the upper extremity. Depending on where we deposit the lower extremity, here around the roots and trunks, we can numb up the shoulder. Further down, the divisions, the cords, and the terminal branches, we could numb up and anesthetize the distal part of the arm, the elbow, and the hand. Similarly, this is the lumbar plexus as it goes down to the leg. We could give numbing medicine to the hip, the knees, and if you approach it from the back, the sciatic nerve and the lower part of the leg. For a very long time, we've always known, this has been going on for decades, regional anesthetics make patients more comfortable. They take less opioids. There's less adverse opioid events, the stuff we talked about, the nausea, vomiting, the sedation. Patients sleep better. They get better rehab. They can do physical therapy better. Their length of stay is decreased. We could send them home on same-day surgery because of these nerve blocks, and satisfaction is significantly improved. But what if I told you not too long ago, maybe a decade or two ago, anesthesiologists used to go in with a needle while we're placing these procedures, and when we poked your nerve, you would say ouch, and we knew we're in the right space. We've come a long way. I actually never had the benefit of training under that method, but when I first started training, we used to go in with a needle with an electrical current, a nerve stimulator. And as we approached the nerve, the current would stimulate the nerve, and you'd get some type of a muscle twitch. And depending on which nerve you're touching, you'd get a certain type of twitch, and you kind of knew where you were. It's interesting, when ultrasound came along, they started doing combined nerve stimulator and ultrasound techniques. And they found that in order to elicit twitch, you still needed to often, significantly, like 60, 70, 80% of the time, actually enter the nerve in order to elicit that twitch. These are my two favorite toys at work. They're the two ultrasound machines. They're the latest and the greatest. Now, in real time, I could see the nerves, the surrounding blood vessels, the muscles, all the surrounding structures. I could see my needle in real time. I could see the medicine, the local anesthetic, as it's deposited around the nerve. And I'm pretty confident I could get a good and safe block. This is the first ultrasound image. It's an image of an interscalene block, which we use for shoulder surgery, whether it's rotator cuff, shoulder arthroscopy, or shoulder replacements. You can see here's the subclavian artery. It's the main artery that delivers blood to your arm. It sits on top of a horizontal white line, which is the first rib. Here you can start seeing lung tissue, which gives you an idea of how a lot of times when we do these procedures, we're next to many vital organs. Right over here, at this point, it's still not very well developed because it's the divisions of the brachial plexus. We could see the nerves. And as I click, you're going to start seeing, as the ultrasound probe moves from the top of the clavicle up higher, we'll get to the interscaling groove. Here are the divisions of the brachial plexus. As I go higher up in the neck, you can start seeing the anterior scaling, the middle scaling. Here we have the C8 nerve. This is the C7, a split C6, and a C5 nerve root. You can start seeing the carotid and the EJ in view. And so I could, based on where they lie, how they look, I know which nerves I need to anesthetize. For shoulder surgery, we go for C5 and C6. Further, as we go further up, I could confirm I know which nerve is which. I know this is C5, C6, because as it enters the spine over here, it has a prominent anterior tubercle. As we go further, this is the C5 nerve root. You can see it's more equal, like a hammock shape. One's not more prominent than the other. And so I kind of know exactly which nerves need to be anesthetized. The benefits of ultrasound is definitely, I think, easier. You kind of know exactly what you're doing. You know you're going to get a good block if you know what you're looking at and if you give the medicines in the correct place. It's been shown to be more efficient. You can do these blocks faster as opposed to going in with a nerve stimulator and redirecting your needle just because you got not the correct muscle twitch that you wanted. Patients are more comfortable. If you've ever seen these blocks with a nerve stimulator, it makes their arm move. If they have a fracture, it's very uncomfortable to have that muscle twitch. You don't have to do that anymore. I would argue that they're safer, especially for certain blocks. And for certain blocks, you could definitely get more successful blocks, whether there's some of the orthopedics blocks or some of the abdominal blocks that we do. So I'm a big fan of them. Let's take it a step further. We can talk about perineural catheters. Regional anesthetics are great, but as soon as you give that local anesthetic, that numbing medicine, it starts to wear off, about usually 10, 12, 15 hours later. For more painful surgeries, what we have the option of doing is putting a catheter in there. Very similar in a lot of ways to an epidural catheter when somebody's having labor, because you need the numbing medicine to last a little longer. So we could place these catheters near the nerves, hook it up to a pump, usually infuse for about 2 days, and extend the duration of the numbing medicine. We could send patients home on these with these pumps, and we've seen some great results. We most often do them for total joint replacements, total shoulders, total knees, or significant outpatient shoulder surgeries like rotator cuff injuries. This is the same patient as we saw before. You see the trunks of the brachial plexus. You can see a needle, a 17-gauge 2E, approaching the nerves. This is about 2 centimeters, so you see as you get really close, you're less than a millimeter away. But the nice thing is I don't have to enter nerve. We don't have to touch the nerve. We just get as close as we can. And then as the catheter will leave, you can see it just sits right next to the C5 and the split C6 nerve. The needle is coming out, the catheter stays behind, and that will stay in there for 2 days. So putting it all together, this is the cartoon again of the multimodal, the mediators that we could use to control pain after surgery, mediators that could mitigate the pain sensations, the pain signals that go from the skin to the brain. About 2 years ago, Tori Kroll, one of the clinical coordinator for our total joint and spinal fusion programs, approached us to see if we could use these techniques and add a true multimodal regimen to improve the care of our patients. And what we did is we tried to minimize the opioid pain medications, and we used a lot of these things that are highlighted over here. Everything from NSAIDs, local anesthetics, to steroids, gabapentin, pregabalin, ketamine. We developed a very specific protocol tailored it to each surgery, to each patient, to improve outcomes. And I just want to show you some data of how successful it's been. So I want to acknowledge Jim Duffy, who is a computer whiz who works at the pharmacy, who helped me collect all this data, which was a lot of it was pre-Epic and hard to collect. So as I said before, one of the aspects of multimodal regimen is something as simple as Tylenol. When I tell patients about this, or even doctors, it's hard for them to believe how effective that could be. But if you think about it, we add it to oxycodone to give Percocet for a reason, because you add a Tylenol to an opioid, it really makes it more effective. So you could see in a period of about 3 months, these are our joint replacement surgeries for knees and hips, we significantly increased the amount of Tylenol we were giving patients. And at the same time, we decreased the amount of intrathecal morphine or Duromorph that we're giving to the patients. What happened in that time? In the first few months, a third less opioids that the patients were using their entire hospital stay. We find that they weren't even, they seemed so much comfortable, but they still had a PCA, and we were still noticing they were pressing their PCA button, didn't think they needed it. So about in January, we went through a trial of taking away the PCA, and they needed even less opioids. I hear stories from nurses that in the past, it'd be a good day if the patients could get out of bed and walk to the bathroom on the day after surgery. And now I think there's a lot of physical therapists here who would just acknowledge that patients are walking the hallways on a regular basis. And if they're not walking the hallways on a regular basis, there's something's not right. And we have to figure out, because they should be comfortable enough to do that. Nausea, vomiting. A third of the patients used to be nauseous. Usually, I think the Duromorph was a major reason for this. About 15 to 20% of them would be throwing up. And we got that down to about like 5% for the first 18 to 24 hours of the procedure. So patients were doing a lot better. So I hope I've showed you that we've made patients more comfortable. We've decreased the amount of opioids they've taken. They're getting less side effects, less than 5%. Safety, I have to acknowledge Al Taglavia, Dr. Taglavia, who about a year ago took these patients and gathered some data, got about 3 years worth of RRT data for the hospital for these patients, and he significantly showed that the amount of RRTs, rapid response teams, or emergency for these patients decreased. Patients were not sedated as much anymore, so it's not only just comfort. We already touched that. The rehabilitation is a lot easier. The patient satisfaction scores. The hospital always has very good satisfaction scores, but with the implementation of this program, we were tops in the country for joint replacement surgeries. It was very impressive. I think with all this, you get better outcomes. And of course, I don't have any data, but there is data out there that when you get patients more comfortable, it is cheaper in terms of nursing mind power, in terms of medications to treat nausea, vomiting, Foley's for catheterizations. It's a good deal all around. So in summary, I just want to leave you just to keep in mind that there is a traditional way to maybe move away from just using opioids. Try to think of other ways we could care for our patients and let them rehab and get better, back to normal faster. Today we heard a lot of fascinating talks about orthopedic procedures, the newest and the greatest. And if there's anything we could do to make patients more comfortable and rehab better, keep them safer, less RRTs, I think we'd be doing them a huge benefit. So thank you, everybody, for listening, and take questions a little bit.